Started with thinking about some of the issues with the deceased donor allocation system that kind of prevent it from operating optimally. So, first, there's this paradox where there's this really long wait list for kidney transplants, but approximately 1 in 4 recovered donor kidneys end up going unused. And then subsequently, there was a study that found that 62% of the kidneys that go unused in the US would have been allocated under France's allocation system. Now they have a much more liberal system and a much more homogeneous population than the US, and it's much smaller geographically. So there's a lot of factors that go into that. But essentially, it's that the quality of kidneys that are being unused in the US would be used in France very frequently. So one of the reasons for this had that's been pointed out was maybe that transplant center performance metrics, such as post-transplant patient and graft survival, waitlist mortality rates, and transplantation rates are going to bias against transplants for older and sicker patients. So performance metrics may also cause more conservative selection of donor kidneys, wanting to use the highest quality kidneys possible. So one study found that older candidates had expressed a willingness to trade off kidney quality for shorter waiting times. And so we have this potentially um, pool of usable kidneys that will otherwise go unused, and a patient population that receives a disproportionately low share of kidney transplants that may be willing to accept lower quality kidneys. So we thought it was logical to estimate the benefits of allowing older candidates access to lower but acceptable quality kidneys. So, in the scenario where we could increase the rate of transplantation among older candidates by 25% using these lower but acceptable quality kidneys, we estimated first that it could reduce the number of waitlist deaths and waitlist removals for reasons other than death or transplantation. So, first, it's improving the waitlist outcomes, but also, um, there's the other side of things where the lower kidney quality is associated with the increased probability of delayed graft function, which is something that we want to avoid. However, shorter waiting times, which are an effect of increasing the rate of transplantation, has that opposite effect. So the two effects end up canceling each other out in a way where if we're able to increase the rate by 25%, it's actually see a similar rate of delayed graft function. We're also seeing increases in quality of life and longevity. So we're seeing just overall improvements in health for this population. Um, and then if we consider costs associated with the transplant process, we find that it'll increase the cost per person. Uh, but if we use conventional cost effectiveness thresholds, which we would define as $100,000 per quality adjusted life year gained, that's a standard metric used in cost effectiveness analysis, that we're therefore well below that threshold. So therefore, it'd be cost effective to do so. Um, and yeah, so that's kind of the summary of those findings. Although cost effectiveness is generally not considered when making policy decisions in the US in the same way that it is more explicitly used in places like the UK, I still believe it's important to know that it's possible to improve health outcomes for older patients while having a minimal impact on healthcare spending. In fact, if we consider the substantial patient and caregiver time associated with end stage kidney disease and dialysis and post transplant care, increasing the rate of transplantation by 25% is actually going to be cost saving to society. So, to be clear, the cost effectiveness and cost savings are secondary to the improvements in health of the population. However, it is, I think, good to know the impact that it's going to have on healthcare spending.